All right. I'm going to start out with just some brief intros as people file in. We are joined here by Jonathan Wolfson. Jonathan Wolfson is a senior fellow here at the Niskanen Center. He previously led the policy office at the U.S. Department of Labor from 2019 to 2021. Prior to that, or right after that, he served as a chief legal officer and chief policy director at the Cicero Institute, where he spearheaded state-level reforms to expand patient access to care. This is when he was working on this issue a lot. And we're also joined by Dr. Ilan Shapiro from Los Angeles, who is a physician, healthcare policy workforce leader in Los Angeles. He currently serves as AltaMed's Medical Director of Health, Education, and Wellness. And then we're also honored to be joined by Representative Tom Oliverson. Dr. Oliverson is a policymaker and a physician serving Texas's District 130. He was the lead sponsor on the Doctor Act, which we'll get into in a little bit, a bill passed earlier this year that opened new licensing pathways for international doctors. Thank you, all three of you, for coming. Before we get going, I just wanted to share a little bit about kind of the doctor shortage, why this issue is important. Niskanen actually recently published a paper written by Jonathan and I and our colleague Catherine Hall, kind of focused on sort of the next step of this question. We now have over a third of states in the country that have passed new licensing pathways for international doctors. And there's a lot of questions about what's next. How do we ensure that states implement these laws so that patients have access to care? And the reason for this movement is really the doctor shortage. I'm going to go ahead and share my screen here. We have in our paper, we talk about one really important part of the doctor shortage, which is the residency bottleneck. We currently have, if you look at this year, over 40,000 MD graduates sought a residency match after finishing their medical degree. But as you can see here, over 9,000 actually were not able to match. Now, you may think that this is evidence of a really competitive healthcare market for doctors, and certainly that's part of it. And we want the US to have a really competitive process. But the reality is that a lot of these folks didn't match simply because there wasn't a residency spot for them, not because they weren't qualified or didn't have the required credentials. This residency bottleneck has created the need to think about how we can bypass it, and this is where essentially states come into play. Because Congress has so far been unable to provide the funding needed to increase slots, to ensure that everyone that wants to be a doctor can be a doctor and get licensed. So states have had to step up to the plate. And so now you can see here, this is a new chart that Jonathan and I worked on, kind of a new survey of states. We have now about 20 states that have created full permanent licensure paths for internationally licensed physicians. And you may ask yourself, what are these licensing pathways? Essentially, they allow international physicians who completed their residency training overseas and are licensed in their home country to begin practicing in the United States at a state licensed facility that employs other fully licensed doctors. Every state has sort of a unique twist on their requirements and credentialing processes, but that's sort of the bare bones of what each state is doing. The reason these licensing paths have sort of transformative potential is because they're able to bypass the residency bottleneck. We can leverage international training and the United States supervision system to ensure that we get the doctors of the highest quality to meet patient demand. So let me stop sharing here, and then we'll get into some questions. I'm going to start off with Jonathan. You've been a leader on this issue, one of the architects of this reform. Can you walk me through the last few years? How has the appetite and the discourse kind of changed on this issue?
Yeah, thanks, Lawson, and good to be here with my friends, Dr. Shapiro and Dr. Oliverson. And, really, these conversations have been happening for a long time. And the challenge has traditionally been that you would talk to someone who's a leader in this field, like Dr. Oliverson, and he would say, yeah, we see the shortage, we're practitioners, and we see that this is a problem, and he's got constituents who call him, or Dr. Shapiro would say, we've got a clinic and we have patients who tell us all the time that they're having a difficulty accessing care. But once you kind of take that conversation to the next level and you talk to folks who might might start worrying about the quality of education, and then they kind of forget how doctors get licensed in the first place in the United States. And so people start having these beliefs that only someone who went to the medical school down the road from them could be qualified to practice medicine, despite the fact that A third of doctors practicing in the United States didn't go to med school in the United States and are delivering really great care to patients every single day. And despite the fact that the data all indicate that these shortages that we have in the United States are only getting worse, right? The shortage conversations, Dr. Oliverson and Dr. Shapiro could tell you, used to be conversations that were limited to rural areas. And it was a conversation about in rural areas, they're having a hard time finding especially specialists. But now these shortages are all creeping into urban areas and into the suburbs because doctors are also, just like the population of the United States, getting older. And as a result, those doctors want to retire just like their friends and neighbors. And so you're ending up seeing a reduction in the total number of doctors practicing, an increase in the demand for doctors. And there's been all sorts of solutions that states have tried to approach. And what I've really seen over the last few years is the conversation go from an instantaneous no to there's no, from conversations with medical associations and medical boards who would just say there's no path other than the one we have right now. It's just the one we've always done, to a willingness to say, wait, there might be alternative solutions that really can allow more doctors to practice in the United States, that don't require scope of practice changes, that can allow doctors to touch patients and really deliver care to those patients. And I think that this has also been a conversation that has been very bipartisan. You start some of these conversations, and initially you might get pushback from one party or another, and often it was kind of whatever party was in the minority was opposed because they were like, "Oh, what's the majority party trying to pull over on us?" But once they started to talk to the advocates and allies on these topics, they realized that the doctor shortage affects conservatives and liberals. The doctor shortage affects people of all colors, skin, all age ranges, from every congressional district, every legislative district in every state. And so those people need access to care. And so then once people kind of got themselves to that place, the conversations really did start moving into practical conversations of how do we figure out a pathway to allow doctors who are licensed abroad and have been practicing and treating patients all over the world. In fact, there's even Americans who will go see them overseas. How can we help those doctors get licensed in the United States and create a pathway so that they don't have to that earlier slide, they don't have to take up those residency slots? So that's really where the conversation has gotten. And it's just been amazing over the last 5.5 years or so to see it go from a concept to a reality in a number of states.
Yeah, thanks, Jonathan. And turning to you, Dr. Oliverson, you were able to essentially a monumental achievement in Texas through the Doctor Act. You're the lead sponsor on that bill. What drew you to working on this issue as a physician, and why do you see it as sort of one of the critical components of solving the physician shortage?
Yeah, it's a great question, Lawson, and it's obviously I'm really overjoyed to be on the call with you and with Jonathan and Dr. Shapiro, and our guests. I started working on this 4 years ago, and like a lot of bills, you file it the first time, you have a conversation. It doesn't, just sort of take off and fly like the Wright brothers. You have to go through a few iterations before you actually take flight. So we learned a lot. But basically, my interest in this came from a mixture of my own experience as a physician, in private practice, and the shortages that we are seeing, that I am seeing, in terms of not having not just access to primary care, but critical specialties, including my own specialty of anesthesiology, where there just aren't enough medical graduates going into and graduating from these training programs. And quite frankly, not only is the pipeline long, and the time needed to train somebody from the day that they graduate from high school to the time they're practicing medicine is basically more than a decade in all cases. And so no matter what we did to try to expand the number of medical schools, which we have done in Texas, and I think Texas has set a record, and certainly a model for states in terms of expanding GME spots to make sure that, as many Texans are graduating from medical school, that there's a place for them. But it's not enough. Even if all those spots are filled, which they are, the shortage continues to grow, and COVID obviously didn't help us with that. So, I started thinking about the fact that my own training program, and I would be willing to venture that this is true for every training program nationwide. There's probably at least one faculty member that American medical graduates in graduate medical education and residency training programs learn from and are trained by who is not an American medical graduate themselves. So this is not a new concept. In fact, in my institution, I had I had several cardiac anesthesia attendings from South Africa, a couple of pediatric attendings from McGill University in Canada, and one physician attending who was a big influence on me who had trained in the Philippines, who taught me everything I need to know about doing upper extremity blocks. And so, you know, why aren't these people, if they're already here, and a lot of them are, why aren't we using them? And then the other thing I saw is that got me really interested is I started talking to these folks who spend their days helping our obstetricians do C-sections. And basically they're licensed as a surgical assistant. And you start talking to them and you find out that they're a fully board certified gynecologist obstetrician with 15 years of practice in Central and South America or Mexico before they came to the United States. And the only thing they can do in the US is close skin, despite the fact in their home country they have logged over 10,000 deliveries, and have a very good track record. So I'm thinking, why aren't we using these people to fill, especially in a state like Texas, where we still have over 200 of our 254 counties don't have a single practicing obstetrician, no maternal health care. Why are we not creating a pathway for these folks? So, as I said, it failed the first time. We got a little bit in the air, but it didn't fly. So I went to work with my friends at the state medical board, and they went to work with the Federation of State Medical Boards. And we developed some language that we implemented in that Doctor Act, which for the most part has been accepted, I think, by the widest variety of states we've ever seen interested in this. And that's what we're moving forward with. And so it not only creates a pathway to licensure, but it potentially even opens the door to future board certification here in the United States, which I think most of our listeners would probably recognize is equally, if not more important than having a state license, is having the ability to be board eligible and ultimately board certified.
Yeah, that's great. I want to turn before I turn to Dr. Shapiro, actually, just for the attendees, if you have questions, there's a Q&A option down below. Feel free to use that. In about half hour or so, we'll start taking those questions. But Dr. Shapiro, you're in Los Angeles. California has a slightly unique version of these pathways. Texas passed something pretty broad. California has a very narrow pathway called the Mexico Pilot Program. You help the nation's largest independent, federally qualified community health center build their workforce in care for patients. How do those pathways, like Mexico's pilot program, help you meet your patients' demand for care?
Thank you so much for the question. I'm going to walk a little bit back on how that program actually worked, but also give you a little bit of my background. I was born and raised in Mexico City. I had the opportunity to work in Chicago, Fort Myers, Florida, and right now here in California. Then everything that holds true, that we actually need a physician to give insulin to our patients, to make sure that our patients are taken care of. And the preventive part of it, it's extremely crucial. And also, if we align the culture and linguistic concordance, actually helps also have better outcomes. Then backing down to 2000, where California saw a problem. There were actually important shortages in rural and also urban settings where we had the patients, we had the clinics, but we didn't have anybody to actually give the service. Then early on had two pilot programs. And the idea was to actually, first of all, there was the same way that Dr. Oliverson and also Mr. Wolfson have mentioned, there were a lot of questions about how they were trained, how they were doing things, and we needed to actually prove that the concept was actually something workable, make sure that we were moving forward, and also, making sure that we had access to physicians and making sure that the quality and outcomes were, on par of the American standards. And that's the way that the Mexican Physician Pilot Program actually was born. At the beginning, there were the idea of bringing 30 Mexican physicians. And the idea of this was that it's a controlled setting, validated by, UC Davis, USCF, like different entities around this to make sure that, everybody was telling the truth, making sure that the notes were there, that the patient's outcomes were there, and continue to actually monitor the physicians to actually tweak it, and most importantly, bring those services into the community. And what actually started as a pilot program with 30 physicians for 3 years, and that's one of the things that there's a lot of opportunities there where we have those 30 physicians. They are in rural and urban settings, serving the community, but sadly, they need to go back after 3 years. There's no path for us to retain them. There's no path for them to go like, well, you know what? I actually like this, and I want to continue serving the community. Then we do not have that pathway. It's something that is a great opportunity to California. At the beginning, that was 2000, and right now we're in 2025 when we're recording this. Then it has been 25 years. Then there's the opportunity to align already the experience that we have in California, because we did have those research opportunities, that data points, that I think that, feeling at peace that we were doing the correct thing for our communities and move it forward, because that's the opportunity. We acknowledge that it worked. We expanded the program from 30 physicians to 150 physicians a year. But still, with that 3-year limitation, that that, and Dr. Oliverson has done this. I have done this, and I'm talking us as not physicians, but as patients. When you actually find a doctor that understands you, that actually talks, never mind your language, but talks to you, it's hard. Then evolving that and actually losing them, it's horrible, because you need to start again with the next generation, next generation, next generation. And this actually starts a conversation of opportunities where we want to deliver long-term outcomes, people that will stay here, physicians that will make a huge difference for urban and rural settings. We, at the end of the day, all of us need help.
Yeah, and Dr. Oliverson, legislatures can pass laws, but ultimately the group that's in charge of implementing them, making sure that folks get licensed, checking all the boxes is really the medical boards in each state. You were able to successfully partner with your medical board, I think, in a way that's pretty unique in Texas. So can you talk about how you got kind of broad buy-in from those on the medical board? And do you have any kind of suggestions for other state lawmakers that may be on the call, hoping to build similar kinds of partnerships with their medical board?
Yeah, so I should say that I was lucky and blessed to not only have an excellent coworker in the Senate, Senator Sparks, who saw this idea and literally made it his top priority too for this session. So we were both working on it together. But during the interim, after the last session, I actually have a good friendship already with the president of the Texas Medical Board, Dr. Sharif Safran, who also is on the Federation of State Medical Boards. And we worked very well together collaboratively. I think after I sort of explained to him what I was trying to do, he very quickly saw the importance of the vision, of like, look, we have all of these doctor shortages, all of these medically underserved areas. And so he kind of did a lot of the work, and I have to give him a lot of credit for this, because he was the one that actually went as a member of the Federation of State Medical Boards, that actually went to the FSMB and started working on this and saying like, okay, well, we have something in Minnesota, but, a lot of you don't like that. And so like, what does it actually need to look like to where a supermajority of states can agree that essentially this is a good licensure pathway? Because one of the things that we've seen in the past with this is that you get licensed in a state, but every other state doesn't recognize that. And so what we wanted to achieve was to have some type of licensure that would ultimately, after you completed the pathway and you took all the exams and you proved that you had the knowledge, and we had, case records, and we knew you were practicing to the American standard of medicine, that you were on even footing with an American doctor, and that you had the ability to practice, because shortages are everywhere, right? And I think a lot of the other states saw interest in this too, because they're thinking, well, okay, let them work on this first, but then, we'll come along afterwards. And then, this helps everybody, right? Because as people migrate and such in the United States, doctors are going to go wherever there's the best paying job and the most need typically, or where they want to live. So I would say that to anyone who's aspiring to work on this, the buy-in from the medical board is crucial. And like I said, I'm not going to say it was, because I'm just such a great, gifted, speaker or anything like that. I have a good friend who happened to be in the position that he's running the medical board in Texas. And so when I shared the vision with him, he immediately got it. And he's like, yeah, I want to help you with this. This is great. We need this. Texas needs this. So a lot of credit goes to leadership there at the medical board, that they recognized the vision and made it their own. So we've had a very, very successful time. We're in the midst of rulemaking right now. And the medical board is just really taking ownership of this. They're not dragging their feet. They're not like, oh, woe is me. What are we going to do with this? I mean, they had a plan for how they wanted to implement this before the ink was even dry from the governor's pen. They knew exactly where they wanted to go with this, and they were talking to other states simultaneously, keeping them informed of what was transpiring in Texas. So I think you bring up a good point, Lawson. It's really, really important to have that good relationship with the medical board.
Yeah, that kind of cohesion is critical. Texas passed this bill earlier this year, and the expectation is there will be rules promulgated at the beginning of next year, which is a really remarkable turnaround. So congratulations on that. Jonathan, unfortunately, not every state, I think, has had the same kind of buy-in from their medical boards. Can you walk us through maybe what you've noticed, or potentially some pitfalls where you can result in delays or implementation struggles, and how other states have navigated that?
Yeah, great question, Lawson. And I think that Texas really does have a shining example. Idaho was similar, where the medical board and the legislature were working hand in hand. I think there is a handful of states where the members of the legislature saw the need. The medical board was approached at some point, and maybe for whatever reason, I'm not going to try to identify what the motives were, but the medical board wasn't necessarily as excited about the idea, but the governor and the legislature were. And you saw medical boards say, well, we're going to try to figure out how we can delay this process, right? What can we do to, even though the legislature and the governor have said that we have to license these folks, we're going to do it. And some of it is totally reasonable considerations that the members of the board, they say, hey, well, what does supervision look like? We want to have really detailed requirements for all of these specific things, and we're going to write lots and lots of requirements. But a lot of that misses the ethos behind these bills, as Dr. Oliverson was pointing out, that this is not about somebody who went to fly-by-night school and snuck across the finish line of passing an exam and has never touched a patient, and letting them suddenly go off and practice by themselves in the middle of nowhere and treat patients. This is about letting folks who have years of experience, have delivered lots of babies, have, talked to lots of parents about how to treat various ailments for their children for years, or have even taught here in the United States and elsewhere around the world. They've taught people to practice medicine. This is about letting them have access to touching those patients. And so I think one of the really important things that some medical boards are not being thoughtful about is, what does supervision and what does this pathway look like? Because if you make it too onerous, then that doctor that Dr. Oliverson's talking about, who has delivered hundreds or thousands of babies in Central America, if you say every single delivery you do between now and the 4 years when your provisional license is over, you have to have two board certified OBGYNs standing right there next to you. Well, that means for the doctor's practice, for the hospital, they're going to spend a lot of money having to do it, and they're never going to do that, right? Like, that makes it more onerous for them. They're never going to hire that person. And so if we really want to address the shortage of doctors, we're going to have to allow the doctors who have the skills and experience to go out and treat patients. Now, I'm not saying that means that no one evaluates what they're doing. I'm not saying that that means that they can hang a shingle tomorrow, because all of these pathways are provisional licenses where they have to be employed by a healthcare facility. But if someone worked for AltaMed in California, Dr. Shapiro and the leaders of his team are not going to let someone they don't think is capable of treating the patients get in there and touch a patient without supervision. But if they've got someone who's really good and has been on a provisional license for 2.5 years, they're probably not going to supervise them with the same scrutiny because they don't need it. They've seen that that doctor has the skills and ability. So I think that in a lot of cases, it's the medical boards partnering with the licensed healthcare facilities, partnering with the licensed practitioners in the state and saying, what do we need as a state for practitioners? And how can we make sure that this pathway is not as onerous as it is, not more onerous than it needs to be, as a pathway that allows these doctors to come, use their skills, training, and experience to treat patients right away and to grow their own practice so that they're able to be a practitioner, not just like in California for 3 years, but for many, many, many years into the future.
Yeah, that's great. I'm going to step back just a little bit. We'll get back into some of the details on implementation here at the end. But just a step back, I think the main talking point around the doctor shortage often tends to be about rural access. And I think sometimes there can be a misconception that that's the only area in the United States where we have an issue with doctors or a shortage. So Dr. Shapiro, you're in an urban area in Los Angeles, and you've been able to learn some lessons throughout your time, kind of overseeing more of healthcare strategy, looking at LA and how to get folks access. Do urban areas see similar challenges?
When we think about rural areas and areas of shortage, we usually think about green pastures and a lot of things, and it's not real. The reality is that we have humans and concentrations in each city, and that it's across the border. Every state actually has those shortages at rural areas, suburban areas, and also urban areas. And I'm talking about big, large cities. You can think about Los Angeles, you can think about Miami, you can think about many big cities where, if you're looking for a doctor that will take care of you, the waiting time is long. And it's not because they don't want to see you, it's there's human limitations on how many patients we can see. And that's the reality that we're seeing. And at the moment that, yes, we want to create for sure that path for education here in the US. We want to create more residencies. But if I have a patient today that has diabetes, high blood pressure, has, history of a stroke, or, right now has an issue with his heart, they cannot wait 10 years to actually get treatment. It's something that it's impossible. Yes, we want to be stable. We want to actually create our own. Yes, yes, yes. And at this moment, this path can actually put us on track to make sure that we're meeting where our community and populations actually are, the needs that they need. Then from Los Angeles to Miami to any other state, we should be thinking about this as something that can bring that, close a little bit that gap. Is it going to be perfect? I would love to tell you that the people that we have here in front of us have the perfect answer. No, this is actually part of a broader conversation that we need to move forward. But if I need to give insulin today, I need a prescriber. I need a physician that will take care not only on the insulin part, but also take care of the wholeness of that person to make sure that they are moving, that they are eating better. And if we do not have that opportunity for that person, at the end of the day, they will end up on ER, complications, and at the end, will be a sicker community. And we have the tools right now across the country to improve that outcome.
100%. Actually, I'm going to incorporate a question we just got focused on, they're asking, we can do these kinds of changes, but ultimately the employers are the ones that have to hire the doctor's license under this new pathway. I'm going to direct this first to Jonathan, but Dr. Shapiro or Dr. Oliverson, if you have thoughts, feel free. Jonathan, what are some of the challenges that employers might face in actually hiring doctors licensed under these new pathways?
Yeah, so as a lawyer, I can tell you that every time some organization is going to hire somebody, the lawyers are always like, "What are the risks that we're taking in those situations?" And I'm sure that the lawyers at the hospitals, the lawyers at the practice groups, are all saying, "Well, how does this look in litigation if we go forward and we have this person practicing with us? And how are they going to get medical malpractice insurance? And are we doing credentialing the same way that we're doing it for everybody else, so that if something bad happens, we have a good story to tell?" And so I think that there's a natural risk aversion to letting unique new things happen. And that's not just true in medicine, but it happens in medicine as well. And that is probably less caused by the doctors and more caused by us lawyers who create complications across lots of fields. But I think that complication is there. I also think that, kind of to my earlier point about the medical boards, if those medical boards start larding up the relatively streamlined bills with lots of additional requirements in the name of safety, in the name of transparency and data reporting, if suddenly, in order to have a internationally licensed doctor treating patients, you have to file an extra 10 pages of electronic health records for every visit, then guess what? The doctor's offices are going to say we can't do it. And so they're just going to say we'll just continue to have our shortages. And so I think that the reasons that the practice groups, the hospitals are taking kind of a wait and see approach in some of the states even that have already passed these bills is because they want to know, if they bring these doctors on board, are they going to be paid when they provide services? Will the insurance companies, will Medicare treat them as doctors? And some of those things are already being addressed. Will the medical boards require all this extra paperwork? And so long as they aren't going to, then it makes a lot of sense. Because every time I talk to a hospital executive, every time I talk to somebody who ran a practice group, and said, "Does this idea make sense? Would you hire these folks?" Every one of them said yes. And so I think that they have a desire and an interest in hiring. What they need is to know that it's not going to be treated any differently than every other doctor they hire. And so then, just like when they hire a brand new doctor who just finished her residency, and there are obviously going to be supervision and other things they're going to do with that doctor that are very different than what Dr. Oliverson or Dr. Shapiro have, I guarantee that they're not having someone stand over their shoulder every time they perform a procedure. But when they were young doctors, there were people around even after they completed their residency. And I think that giving those businesses the flexibility to say, we're going to observe these doctors in the way that makes sense for our business, is going to be the thing that really opens those pathways up for the businesses.
Yeah, that's great. Another sort of, I think, thing you hear on this issue is, what about U.S. trained doctors? Do we not have U.S. trained doctors that can fill these roles? Obviously, I showed at the beginning the residency bottleneck. Dr. Oliverson, can you talk about how this pathway may actually open up more opportunities for U.S. trained doctors?
Yeah, absolutely. In a couple of ways, actually. I think number one, right now, if you're a foreign trained medical doctor, fully board certified and licensed in another country, about the only way that you can fully practice as a U.S. physician is to go back and do your residency over again. And so right now we see foreign trained doctors competing with American medical graduates for graduate medical education spots, and winning in a lot of cases, because that's the only pathway available to them, which is completely unnecessary. They don't need to go back to square zero and start over in day one of their internship. They need to be given an opportunity to demonstrate their skills, build a case log, and make the case that they're already board eligible. In other words, that they already have all of the knowledge. So I would argue that by giving them a secondary pathway, it actually creates a little bit of pressure release on the competition that we currently see. You mentioned about 9,000 medical graduates per year not matching in a residency program. And I would submit to you that the other thing that folks typically, if they're not physicians, don't realize is that the match is all or nothing. So you could be in the top 10% of your class and be competing for the most highly sought after and coveted residency for that particular cycle and just not quite make the cut. But you're still in the top 10% of your class, but you get nothing. You end up having to scramble into whatever's left over, which is usually going to be something you probably don't want, especially if you were interested in a surgical subspecialty. And so, we have to get rid of that. The other thing that we should probably throw in and talk about is the fact that, what I'm seeing right now as an anesthesiologist in private practice is that our labor costs have never been higher in the history of anesthesia. And a big part of the reason for that is because we are so short-staffed and understaffed. And I'm talking like literally every mid-level practice nurse, a CRNA who's available is working. Every physician anesthesiologist who's available, who's trained, is working. And the problem is we don't have enough. And so what that's doing is people are coming out, they're realizing if they join a group, they're going to get burned out really fast. So instead, they decide to do locums work, which comes at an extremely high premium. And the cost per hour now for locums for anesthesia is up over $400 an hour. And that cost is being passed on to the American healthcare system, patients, employers, everything else. And it's a fact of life because people are burning out quicker. People are refusing to take a full-time job because they realize that they're just going to get the crud worked out of them because there's not enough people in the field. It is the exact opposite of what people think of when they sort of make a false comparison between what's going on in healthcare and what we're trying to do, and what they keep hearing is happening in the tech sector, which with H-1B visa holders coming in and taking American jobs, and then you got kids graduating and they don't have any jobs. There are no American medical graduates left that are unemployed except by choice. We probably in my own company, just in the Houston area, probably have 20 or 25 job openings for physicians right now that we can't fill. And that's just my company. Imagine nationwide what you see.
Yeah, 100%. And just a reminder to those attending, I saw a couple of questions. If you'd like to ask a question, just type it into the chat and we'll get to it. One question we received, and I'm going to pass this over to Jonathan, and then we'll go to you, Dr. Shapiro, is about how to make sure that doctors licensed under this pathway, that there's like a payment structure set up for that. So obviously, the way Medicare, Medicaid, and private payers decide whether or not they can pay for a service, it is in part due to the licensure structure and credentialing process for the doctor that provide the service. With a new licensing system, a new pathway, we also have to build the system for payment as well. Can you talk through whether Medicare and Medicaid are actually going to be able to pay for these doctors that provide services?
Yeah, great question. So I think part of the reason that strategically, as I was working with lots of legislators around the country and Dr. Oliverson working with the board, that you wanted to make sure this was a provisional medical license fully under the jurisdiction of the medical board is because that way it is still considered a medical practitioner, right? That we're talking about a doctor practicing. We're not talking about someone who isn't a doctor. And so by doing that, you're able to put that person into your billing system as an MD, as a DO. You're not putting them in as a nurse practitioner or a PA or something of that nature. So I think that's the first step because in most cases, that's kind of the toggle that the insurance companies have is this person an MD and licensed as a doctor? And in all these provisional cases, the answer is yes, they are licensed as a doctor. It doesn't, even if you had somebody who gets, a lot of states allow doctors during their residency to get kind of temporary licenses where they'll work at a minute clinic or in an urgent care. Those docs can also bill to insurance in the same way, right? Because they are licensed as doctors in those states. And so I think that's the first step. I think that state Medicaid offices that have not already given clarity to their MCO if they have one, or to the citizenry that they are okay treating these doctors as doctors should do that. It's pretty simple. It's not doesn't take a lot of work because it does again put them in that column of doctors. And I think that once we see Medicaid, once we see the systems billing for them as doctors, the insurance companies tend to fall in line on that. It's not a super complicated thing once that doctor is considered a doctor. I'm not saying that isn't work to do, just like every time you hire a new doctor, you're having to submit paperwork. But by treating these folks as doctors on the very front end, that should alleviate a large amount of the challenge on that piece of it. The other challenge on the insurance side really is the med mal insurance part. And I think that's part of why everybody who's creating these provisional pathways has the doctors work for an established practice. Because it's one thing if that new provisional licensee had to go out and seek med mal insurance on his or her own. But if they are working with Dr. Oliverson's team, Dr. Oliverson's team can say to that med mal insurer, hey, if you aren't willing to cover all of the practitioners in our group, we're going to go look for another provider. And that creates an incentive for those med mal insurers to figure out how to risk rate all these people. I'm not saying they shouldn't do their job as insurance companies, but that does provide an incentive for them to cover those folks and to eventually get some good data to indicate that these provisional licensees are being supervised by the practices in which they work, and they're no more risky as providers than any other young provider might be who's in their earlier years of practice.
Yeah, that's great. And I'm going to go to you, Dr. Shapiro, with one more question, and then we'll do exclusively audience questions from there. Dr. Shapiro, you employ physicians licensed under a version of these pathways yourself. How could states, potentially like California, that have not sort of gone the full route and created an alternative licensing pathway for international doctors writ large, how could those states that haven't participated improve the capture of international doctors that are currently living in their state that are perhaps underemployed?
The beautiful part about physicians is that we have different flavors, colors, and most importantly, we like different climates. And for me, I already experienced the humidity, the snowfall, and right now in California, that it's actually on the mild side. And, probably Dr. Oliverson has his own version of the perfect climate. But the idea of every state to actually participate and open the doors is that, first of all, the risk of being the first one, it's gone. We already have, even in California, that we have not elevated this conversation in other fields, we already have data of thousands of patients and the doctors, the initial doctors group that we had, that this actually works, brings a difference, and validated not only because I said so, but by universities, researchers, and like the medical board, and like different paths to make sure that this is actually working for my state. Then making sure that you understand a couple of things. One is that these doctors have a choice. The same way that Mr. Wolfson was saying that and mentioning that all of us actually will move to a different place where they actually take care of us and we can actually bring our expertise. That's going to happen right now. Then the states that are right now lagging, they will open the door for other states to actually start absorbing them, to actually have a working system. Because we'd love to tell you that at the moment that the bill passes, everything is already aligned. No, they had like some tweaking, making sure that the systems are there, the different payers, there's a process behind it that still takes some time, and it's different by state. Then the longer we're waiting, the longer we are not closing that gap that I was mentioning about giving insulin to our patients, giving that healthcare that our communities and cities and members actually need. Then backing all this stuff, we all want to have a healthcare system, and this is a process that it's taking away almost 10 years of that creation of physicians, of that creation of that pathway. Do we need to continue doing that part? Yes. Do we need to continue figuring out like the med schools? 100%. But at the same time, we need to be realistic. That takes money, that actually takes time, takes effort. What we have seen in the mentioned states that already are enacting or on that path is that they can actually have physicians now in a lot of them. Then why wait? Why wait?
Yeah, totally. So we got one good question, I think, here that kind of talks about sort of how are states actually matching the doctors that they want to get licensed under these pathways to areas in that state that actually need doctors. So how are the state laws actually connecting it to where the demand is? So I want to talk briefly about that, and then I'll direct it to you, Dr. Oliverson, how you guys thought about this in Texas. But a lot of states are kind of create requirements in their law that for the first 4 years that doctors are practicing under supervision, they're doing so in an area of need. Some states have approached that by specifying a rural requirement and then kind of define what the rural areas of the state are. Others have used sort of the shortage area determinations to say, we have areas that, we know from HRSA that are shortage areas. It's almost the entire United States at this point, but that are shortage areas, and we're going to limit a licensure in the pathway to doctors that practice there. There's obviously some trade-offs here, Dr. Oliverson. How did Texas think about this, and what did you guys land on?
That's a really great question from the audience. I would say that we tried to strike a balance because there are two competing interests here. And that is that on one hand, we want to direct these providers into rural and medically underserved communities, which, by the way, medically underserved communities could be in the middle of a large urban city. Los Angeles and Houston, where I am, both have medically underserved communities within the city limits. So I know we tend to think of medically underserved as being rural, but that's not really an accurate definition. So you have that on one hand, but on the other hand, you have the need for supervision and for some measure of being around other trainees and other physicians who are used to interacting with physician trainees that would be in a position to comment on, observe, and perhaps even evaluate a physician's performance as a colleague, as a practitioner. And so what we did in Texas is we require a 4-year pathway to licensure. The first 2 years have to be spent at an ACGME accredited hospital. And essentially, without getting into too much detail, it's a definition that essentially means that there has to be some type of graduate medical training program active where resident physicians are training at that location. Now, what we're not saying is it has to be at a medical school or it has to be at a university hospital. There are a lot of hospitals across the state of Texas that have residents rotating through that are ACGME recognized that are not necessarily the university medical center. But we wanted them to be in a facility that at least we could point to and say, there were other trainees here and there were physicians who were used to training trainees who observed this physician's practice, who interacted, who worked with them, who were in a position to comment on their skill set. Then after that, the second 2 years, we do specify that somebody practices in a medically underserved area. And again, it gets back to a balance. I think Jonathan was talking about earlier of yes, we want them in medically underserved areas, but at the same time, we need to be able to make the case that they were practicing in a supervised enough environment that when we say thumbs up, they're qualified and they can practice, that we actually have a case log, that we actually have a record on them, a file, if you will, that the medical board has assembled so that we can make the case that they've earned that medical license, that in fact we know with a high degree of certainty that they have the same skills and the same knowledge as the American medical trainee would have. So that's the pathway that we took. Now, after the 4 years, they can pretty much go wherever they want to go. And again, I think from our perspective, it speaks to the fact that there's not a county in Texas that doesn't have a physician workforce shortage. In fact, I doubt there's a specialty of medicine in the United States that doesn't have a physician workforce shortage. Maybe dermatology doesn't, I don't know. But for the most part, no matter what you are or where you are, there's great need. So we wanted them to be able to plug in where they want. And I would say one other thing, and that is our pathway also requires them to state at the beginning when they get on the track what their training is in. So in other words, if you're coming from Guatemala and your background is that you're a board certified obstetrician, you will specify to the Texas Medical Board that your training is in obstetrics and gynecology. So we already have that on file and that we know that that's the pathway that you're training towards. We do that for two reasons. One, so that we can figure out, what they're trying to be and where we might need them in the workforce. But also, as I said earlier, we're trying to build a case file for them so that hopefully in the future, they may be able to go to the American College of Obstetrics and Gynecology and say, hey, I should be board eligible. I mean, look at this case file of work that I've done. Look at my track record in my home country. Could I not sit for the exams and prove that I can pass them and I have the same medical knowledge because I've done the work?
Yeah, 100%. Another a question we got is related to how many of these doctors are actually underemployed currently living in the US versus, are these pathways designed for essentially bringing doctors in from overseas? And this is in light of the H-1B potential $100,000 H-1B fee. I'll answer a part of this and I'll pass it off to Jonathan. But one of the interesting things about this is that we have currently a lot of underemployed doctors currently living here, and it's likely not because they came on an H-1B, but probably from a J-1, where maybe their partner or spouse got a job here, and when they arrived, they didn't anticipate the difficulties with getting licensed, and may have just had to sort of be forced, like you mentioned, Dr. Oliverson, working sort of underneath their training. Or we've heard so many stories of doctors driving taxis, working service jobs, just working in medical coding. I know there's one doctor who has a very sort of well-running business doing power washing. So like obviously people are able to adapt, but we want folks to be able to practice to their full. So Jonathan, can you walk us through sort of the visa pathways and how an H-1B fee might affect this?
Yeah, so I think one of the things that, there are lots of doctors, people trained as doctors who practice medicine outside the United States who live here right now. Some of them are touching patients, to Dr. Oliverson's point. Some of them are doing kind of service jobs every now and then. Ask your Uber driver what they did before, and you're going to find out a lot of them were doctors. And, I wrote a piece a few years ago about refugees from Ukraine. And there are lots of folks who come to the United States with medical training and experience. You also have folks who they may be married to a computer programmer who moved here and got a really great job at Google or an academic position, and they left their practice behind, and they are just living in the United States and are not practicing because it was way more lucrative for their family, for their spouse to work at a university in the United States, and so they've just not been practicing. So one of the things you want to make sure in your legislation is you address that, because those people should be eligible to apply. And so you don't want to say that the person has to be actively practicing in a foreign country today in order to be eligible, because obviously that excludes all of those folks. I think that the immigration part of the story is an important one. I do think there's been a lot of overreaction, I will just say, to the H-1B fee discussion. Everything about that presidential proclamation said explicitly that you could apply for waivers. It said that it wanted State Department, Department of Labor, Department of Homeland Security to evaluate who is being coming in on H-1B, whether or not that fee is justified, whether a higher fee is justified. And as Dr. Oliverson said, in the medical field, there wouldn't be a justification to impose a really high fee in order to try to protect American workers, because you don't have any stories. And I'm not trying to pitch this as one side or the other of an immigration story. There are not stories of American doctors who are sitting on the sideline looking for jobs, and those jobs are currently filled by someone from outside the United States. And even if we were to bring in 25,000 doctors from outside the United States, right? The shortage projections are that we're short about 80 to 100,000. So then you would still have 70,000 open jobs in the medical field for doctors. We're not just talking about the medical field writ large. We're talking about for MD, DO doctors. And so I just think that the conversation here is different than a lot of other immigration conversations in the United States. And given that, it makes tons of sense for the bills to say, as almost every single one does, that the doctors have to be legally authorized to work in the United States. I don't think anybody has a concern about that being a requirement for the doctors who would go down this pathway. But once you get there, there's lots of eligible pathways of immigration status, whether that is an H-1B visa, whether that is some sort of green card that they may already have for a variety of reasons. And frankly, there's also a large number of U.S. citizens who are in this boat. And I think that that's the other piece of this conversation that sometimes people miss, is there are kids who grew up in America, moved abroad for whatever reason, right? Their dad might have gotten transferred overseas and they wanted to stay close to family. So they did medical school overseas, or after they were in medical school, dad got transferred and they have a sick relative. So they decided to do their residency overseas and practice over there. They may have married someone, but now they need to move back because they have a sick relative and they want to move back to the United States. Well, guess what? When they apply to get that license transferred, as Dr. Oliverson mentioned, they're not going to be able to without repeating residency. And so this is also a pathway for those U.S. citizens to return home and be able to use those skills and training and experience that they've developed abroad back here in the United States.
Yeah, and part of the question was directly asking sort of how many, doctors do we think are currently living here? I will say one of the issues that we face on this is just a lack of data on the amount of internationally trained physicians. We know that there are, we expect tens of thousands of international medical graduates in the United States actively seeking residency, seeking practice. And I think we can safely assume there are thousands of internationally licensed physicians that are also in the U.S. underemployed. But I want to turn a little bit to we have a lot of international physicians on the call that are watching this, thinking about their own pathways. We got a question from one that was asking like, what's how serious are the chances that if they want to go through the work to go through this process in one of these states, that they actually get hired? I think that's a reasonable fear when you think about all the work that goes into applying for this pathway, even if you've gone through all the work of going to residency. Dr. Shapiro, can you talk through, maybe reassure some of these doctors that are thinking about pursuing these pathways that there are jobs for them?
I'm going to start with we have done harder and more extensive things in our lives as physicians to train and to be anywhere. If you're coming from outside, if you train here, if whatever, we have done a lot of hard things. And right now, most of the requirements from the states that they actually create that path are the same requirements that they would need to do to go to residency. Then that's the beautiful part of this, that it's not that they are being creating a secondary path for them to make them suffer. No, even if they wanted to go to residency, they should have certain licensures, exams, and things like that will standardize the way that we're seeing and approaching absolutely everything. Then that's the first thing, that breathe in, breathe out. The process actually will help you no matter what path you have. Do you want to go? Would I repeat my residency right now? I don't think that my stomach, my heart, or my wife will actually survive me trying to do again my residency. And this path actually opens the door to create that pathway between what we have and also the path that it's standardized. It's not treating us as secondary class physician, because that's very important. They're coming here, and you heard it from Mr. Wolfson and also from Dr. Oliverson, that they're treating as physicians the way that we are to actually help the community. Then knowing that it's the same process. Each state has different flavors, colors. You like the climate, you like the city, or the opportunities. It will differ. That will be a preference from each of us, and how attractive the practices are. Then you will have a choice. And the beautiful part is right now, Mr. Wolfson through the number 30 states, and correct me if I'm on the wrong side, but you have the majority of the states with possibilities for you to find a place that will be compatible for the things that you're looking for. Then I see the opportunity. I see the process as equal to anybody, and also a process that you will do it anyway to be a resident. Then it has all the advantages, with a promise that if you do the correct thing, if you continue the quality and everything else, you have a path to continue serving the community that you're trained to serve.
Thanks, Dr. Shapiro. Before we end, just want to remind everyone, Jonathan and I recently wrote a paper with our colleague Catherine that is in the chat. On that paper, we have a tool there. You can go to the map of states, click on each state. You can get the details on exactly what the requirements are. If you're a doctor that lives in one of those states and is curious whether there's legislation currently in progress, if there is legislation, what it looks like, what hoops you need to jump through to be eligible. You can click on each state on the map and give you that information. We also, if you scroll down to the bottom, we've got an interactive tool where you can search your state, search a different requirement, and see where everyone's at. Thank you, Dr. Shapiro. Thank you, Representative Oliverson. Thank you, Jonathan. We will continue to put out work like this, but everyone stay tuned, and thank you all for joining us. Thank you, guys.